I will just tell you this, that this president cares, and he said it today directly. He cares about not only the Americans who have not yet fallen victim to this epidemic and trying to prevent them from happening, but for those who already had. The president said clearly today that those millions of people need to be cared for, helped, and treated. I don't know if a president of the United States has said it that clearly directly before. Not in my memory. I'm proud of him.
That was New Jersey Governor Chris Christie moments ago outside the White House, where President Trump just declared the opioid epidemic a public health emergency. Christie's the chair of the president's commission on the opioid crisis. And to get a better idea of how this all started, our own Dr. John Torres spoke to a panel of experts in the field of opioid addiction. It's part of our ongoing series, One Nation Overdosed. Let's set this up with a look at the doctors who are on the panel. First up, Dr. Anna Lemke. She's the chief of addiction medicine and assistant professor at Stanford University School of Medicine and the author of Drug Dealer MD, How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop. Next, we have Dr. Scott Hadland. He's a pediatrician and addiction specialist at the Grayken Center for Addiction at Boston Medical. His clinical work focuses on adolescents and young adults struggling with addiction, and his research takes aim at the influence of pharmaceutical money on the rate of opioid prescriptions. Dr. Peter Grinspoon is a primary care physician on staff at Mass General. He teaches at Harvard Medical School. He's a former opioid addict who says he's been clean for 10 years. He wrote Free Refills. A doctor confronts his addiction. Next up is Dr. Angie Rake. She's an oral surgeon who works in multiple private practices as well as adjunct associate professor at the University of Minnesota School of Dentistry. Her advocacy for opioid addiction treatment was inspired by her brother's descent from abusing prescription pills to using heroin. Finally, Dr. Thomas Andrew is the former chief medical examiner for the state of New Hampshire, who recently retired after 20 years of service. His firsthand experience dealing with the breadth of this epidemic inspired him to pursue a career as a minister. Okay, now you know the players. Here is some of their eye-opening conversation.
How do well-meaning doctors who are prescribing medicine to patients that are actually in pain, how do we help fuel this opioid epidemic? What happened there?
Surgery is now a gateway to opioid addiction. So about 1 in 10 people who gets a surgery in this country will go on to become a continual opioid user. That doesn't mean they're addicted, but that means that 3-6 months after their surgery, we have 300 million people every year who have become continual opioid users. That's a setup for those people becoming addicted.
And I think when we're talking about young people, this 1 in 10 number that you mentioned is likely to be even higher.
Probably.
We haven't seen those numbers yet, but we know that the developing adolescent and young adult brain really develops around the exposure to opioids.
Absolutely. I mean, I'm sure everyone at this table has heard the I got my wisdom teeth removed story, and then I got put on opioids, and now I'm using heroin.
That's right.
And the more we saw in our office, the more convinced we were that prescribed opioids after dental or surgical procedures was the gateway, as you said.
Let me switch a little bit to the dental aspect of this, because dentists tend to be one of the biggest prescribers of pain, especially for adolescents.
Correct. Overall, as dentists, we prescribe 12% of opioids, which puts us amongst the top prescribers, and we are the #1 prescribers for patients aged 10 to 19.
Do they really need those opioid pain medications after a tooth extraction or a wisdom tooth taken, any of those things?
The studies are showing that alternatives are just as good non-steroidal anti-inflammatories like Advil, ibuprofen, combined with acetaminophen have been just as effective.
Some dentists will even tell you if I take out a tooth, they need an opioid. You're saying that's not true?
Not in every case, correct.
Dr. Greenspan, you have a unique view here because you were an addict for 10 years.
I was always a straight A student, high school, college, medical school. But the first time I tried Vicodin, it was just different from any other drug I had ever tried. It made me so euphoric, I can't even describe it. And unfortunately, after taking that first Vicodin, I spent the next 10 years of my life trying to recreate that initial high. It was very devastating, my opiate addiction, and it was very, very difficult to get into recovery.
Do we know how to treat addiction?
There is good treatment for addiction. I mean, that's another myth out there, is that, you know, it's hopeless and these people never get better and don't even try.
For me as a pediatrician, one of the things that I do is I treat addiction right in primary care. It's critical that all of us incorporate addiction treatment into our practices.
I agree with every word you said, but across the board, we need to lower the barriers to treatment. Physicians need a special license to prescribe buprenorphine, which is the most effective treatment for opiate addiction. It's been shown to cut overdoses by 50%. But you don't need a special license to prescribe the OxyContin or the oxycodone or the Vicodin that people get addicted to in the first place. So why on earth do you need a special license and 8 hours of training, and you have the DEA monitoring you to prescribe the antidote for addiction? It doesn't make any sense.
But those antidotes, Suboxone, methadone, you're treating an opioid with an opioid.
You are.
And that gets very controversial.
Yes, it does.
Well, I tell you what, when we're treating somebody who struggles with cigarettes, they have a problem with nicotine. What do we do?
Exactly.
We put a nicotine patch on them.
Exactly.
Nicotine with nicotine.
And we don't
Exactly.
stigmatize that. I mean, that's an extremely effective treatment.
You don't need an extra license to do that.
Exactly, and that's exactly what we're doing with opioid use disorder. And we know this treatment works. We know it saves lives. It should not be controversial.
Yeah.
Doctors don't need extra barriers to treat addiction.
Yeah. No
So what do we
idea.
do?
Well, that's a
This
question that
show,
isn't
this
answered.
show is
That's
a good start.
the answer to that's evolving. Like we're in the middle of this epidemic and we're trying to figure that out.
We have to conceptualize addiction as a chronic, relapsing, and remitting illness, and we need to do that even if we don't believe it is one. That is the model for our time. Then we have to build an infrastructure so that any patient struggling with addiction can walk into the emergency room, primary care's office, pediatrics office, the maternity ward, say, I have addiction, will you help me? And the answer will be a resounding yes. Plus, your insurance company will pay for it, right? Because until we get insurance companies paying for it, doctors, no matter how much education you give them, are not going to provide this service. I mean, it's the carrot and the stick. It's very simple.
What a great discussion. Let me continue it with our own expert, NBC News medical correspondent, Dr. John Torres, who joins me now. John, good to see you again. What a great discussion you had. I have to ask you about this. There was a movement several years back, prompted by the pharmaceutical companies, to get doctors and their patients to come to an agreement that pain doesn't have to exist at all, that we can treat all pain, which really contributed to this whole thing. And there are a lot of people who tweet me, and they're really angry that this conversation that we have about limiting opioids is going to make people who legitimately needed the painkillers hurt more.
And Al, you're right. When we had this conversation in the roundtable with these doctors, and these are clinicians that are on the front line in the trenches treating patients right now, they said that exact same thing. They know that back in 2000, 2001, 1999, that this came out saying, okay, we have to treat pain, we have to eliminate pain, and pushing a lot of opioids. That sort of started to cascade. You could point fingers in a lot of different directions, but they said now the big concern is, has the pendulum switched too far? Has it swung over too far? And one of the doctors in particular was concerned that people who legitimately are in pain, and there is a need for opioids in that particular area, are not going to get the ones they need, and they're going to end up suffering for it. And so what these doctors are hoping for is that pendulum swings back a little towards the middle, so that the people that need it actually get it, and the people that don't need it, especially those ones that have that acute illness or acute injury and don't need it right away, don't get it right away.
John, great conversation. Thank you so much for having it with those doctors, Dr. John Torres. And you'll be back with us, by the way, tomorrow with more of the conversation with doctors about the growing opioid epidemic. That was just part of our series, One Nation Overdosed.